Hello, this is Professor Sable. I'm bringing you a voiceover presentation of the lecture on immunology, which will be on the next test. So I wanted to get it into your hands before it was too late to study for it. Thank you. As always, when you come to the learning objectives page in the PowerPoints, you can use these learning objectives to plan your studying because a lot of the tests should be on the questions that are in these objectives. So start there. So as a reminder, the parts of the body that are involved in immunology are some things you might want to go over from A&P. First of all, your body's natural defenses include your skin, the natural flora on your skin that prevents other organisms from taking over. Your body pH is part of your immune defense. You have your inflammatory response, which is usually mediated by macrophages, and you have your phagocytic response from your white blood cells. You also have natural killer cells, tumor killing cells, and you have the memory of those antigens that the cells have come in contact with before to help you fight off disease faster. Also, complement proteins in your body work with the antibody activity to help with that memory. The memory that you get on white blood cells to a specific antigen is actually under the humoral response, acquired immunity. So immunity can be acquired through vaccination or from exposure to a particular organism. So cell-mediated immunity involves the T cells, as I said earlier. Remember that they come from the thymus and they assist B lymphocytes to make antibodies. Immunoglobulins are very important in the blood. So we have IgG, IgM, IgA, and IgE. What you need to notice from this is that IgA and E are not present at birth in the child. So they are that's one of the reasons they're very susceptible to certain diseases after birth because they don't have the natural immunity. IgG is the only one that crosses the placenta. The baby does have some natural IgM. So we can administer those immunoglobulins if needed, but in general, what we want to do is keep the child well until they can build up their own immunity. This is a diagram from your book that you can find, and it might be a good reminder for you to remind yourself how the acquired immunity works. How the cells engulf the invading organism and take a bit of it to be able to recognize it in the future and make white blood cells that are actually going to automatically see those organisms and attack them. This visual really shows you how long it takes the infant's immunity to get up to a serviceable level. As you can see on here, the baby has IgG a little bit at birth, and then it drops way off within the first 8 months, and then it has to climb back up also, and the rest are starting from 0. So IgM gets up to speed first, then IgE and IgG last. Also, you want to remember that the different immunoglobulins have different purposes and functions in the body. So you want to have some idea of that in case that comes up. Sometimes that will come up on NCLEX questions. So when we talk about immunity, we talk about primary immune deficiency or secondary immune deficiency. Primary immune deficiency is a congenital deficiency. Secondary immune deficiency is something that's acquired from either HIV, immunosuppression, or for some other reason the child is having a less robust immune response. It could be cancer treatment, for example, or perhaps the child's getting steroids for some reason, things like that. So we can run certain labs to determine if the child is low on certain immunoglobulins, and certain deficiencies are associated with certain disease processes. For example, DeGeorge syndrome, they have absent T cell functions, decreased T cells, normal B cells. There's X-linked immunodeficiency, where they have reduced immunoglobulin G, A, but they have high M response. So that's just to name a few. So I usually don't test on that, but you should know that there are lab results that can tell you what they're low on, and that could point you in the direction of what's causing it. So there are a couple of other disorders that we want to talk about. Severe combined immunodeficiency disease, or it's called SCID, is a diagnosis that we're seeing more often in kids these days, and it's a deficiency in B cells and T cells. Also, Wiskott-Aldrich syndrome is one of the disorders, again, that's associated with B cell and T cell deficiency, and then of course HIV. So this slide gives a little bit of information. So we know that if you're low on, say, basophils, that it's generally, it can point us to certain illnesses. So basophils are increased in leukemia, but decreased if you have an allergy or an acute infection. So, monocytes have, if they're high or low, that can also point to, for example, leukemia, tuberculosis, protozoan infections. So that gives us an idea of what we're dealing with when we test for those. Some things that are important to remember about all immunodeficiency disorders are what are the nursing interventions that you're responsible for. So you're responsible for recognizing that the child is at an increased risk of infection, that they are likely going to need extra nutrition in their body as far as calories and protein to continue fighting off any disease that they are exposed to. They can often become very thin. Again, so the nursing intervention is to really watch the calories and provide enough nutrition. Immunodeficiencies can lead to a breakdown of the skin barrier, the oral mucus membrane, and so you can get infections in the mouth. You can have a lot of pain associated with various immunodeficiency disorders. Families generally don't have enough information about the problem when the diagnosis is first given. So a lot of education is needed, how to protect the child when they go home from disease. And usually if there's an immunodeficiency disease, that can result in caregiver role strain. So you want to address all those in your care plan as a nurse. So what should your education include? It should include the cause of the deficiency, the treatment plan, prevention of complications, and the needed lifestyle changes. So for example, kids that are, and adults that have immune deficiency, One great example in the hospital is that they can't have flowers in their room. Generally, they're asked to not bring flowers or things because that can actually carry some organisms with it that the child or the patient can't be exposed to. Sometimes, for example, they can't have certain visitors come because even the slightest hint of a fever or sickness in that visitor can expose them to more risk of illness. So you want to, as the nurse, remind yourself of what those teachings are, and then also enforce them if the child's in your care. So they would be in isolation usually. Parents often have a feeling of hopelessness and isolation, and the child being in that isolation it's often distressing for them too. In order to prevent systemic infections, you would want to teach them impeccable hand hygiene. For all of the nursing procedures we would like to do them as sterilely as possible, especially for invasive procedures. So let's say that you're putting in an IV. We usually just do regular gloves, but in this case, maybe you put on the sterile gloves. Just to be sure that we're not introducing any organisms. Make sure that you provide the isolation room and enforce people going in and out wearing the gowns and masks and all those things. Some people just waltz right in past all the isolation gear that they're supposed to put on and don't wear it, and it's your job as a nurse to go in and educate people that are visiting, or sometimes even providers will go in without the proper isolation garments on. So there is a slight difference between immune deficiency and autoimmunity. In immune deficiency, there's a reduction or loss in the ability of the bodies to mount an attack against bacterial or viral invaders and remove foreign substances. So, you know, you want to teach them how to prevent infections and enhance their immunity. In autoimmune disorders, there's a reduction of the ability of the body to recognize self versus non-self. So, and I've talked about this before, what happens with autoimmunity is when your humoral response is being activated to recognize an invading bacteria or virus, it accidentally gets some of your own DNA locked up in its memory. And so if the infection's occurring in, say, a joint, now whenever you have that response triggered, you will have it attacking healthy cells. So that's really the primary cause of autoimmunity, is that your antigens in the humoral response have a bit of your own DNA in them, and they shouldn't. The treatment for that, by the way, is generally you want to suppress the immune response. So they are treated as though they have a immune deficiency after that, but actually they don't. What they have is a hyperactive immunity. So we do suppress it, and we use steroids generally to do that, and there's other immunosuppressants that we can give. As far as autoimmune disorders go, lupus is one that I would want you to know the most about when you're studying. So lupus is generally people think of the butterfly rash when they're identifying lupus, but there's a high number of people that get lupus that never have the butterfly rash. So there's some other defining characteristics of lupus, though. The body attacks the renal system, also the joints, the skin, and some of the brain can also be involved in the immune response. So generally, it's multi-system with lupus. It can be very life-altering for the person that gets it and potentially deadly. So you want to teach people with lupus to have good fluid balance. They need lots of fluid, and avoid stressors, because stressors can trigger an immune response. And that's why sometimes when people are really stressed out, you'll see them break out in hives, because the stress alone triggers the immune response. Also, juvenile idiopathic arthritis is an autoimmune disorder, that's because when an adult has arthritis, it's triggered by years of wear and tear and the pressure of their weight on their joints, that causes inflammation and eventually causes the joints to break down. In juvenile idiopathic arthritis, it's strictly caused by an autoimmune response to those joints. And so, but it's not caused by their weight or their lack of exercise or anything like that. So you want to teach those kind of patients to, they want to do light activity to promote their mobility, but they don't want to overdo it, because too much exercise can, of course, trigger more of a flare-up in their joints. You want to address pain control. You would also do that with lupus, because they're both very painful kind of diseases to have. One thing that's a nursing intervention, if you have a patient that has pain in their joints, you want to log roll them to avoid causing more pain in those hips and knees. And then teach them or help them to do self-care, because often when it's painful to move, they neglect their self-care. So one thing that it's important to do with anyone with an autoimmune disorder is to identify the things that trigger them. So for example, people with lupus are often taught not to go out in the sun, because the sun triggers the autoimmune response in the skin. Other things that can trigger people with lupus: a cat scratch. My sister has lupus, and she had a minor scratch by her cat, but she ended up hospitalized for over a week with it, because there was organisms on the cat's claw, and those, she didn't have enough immunity to mount a response against that. Flare-ups are, so any autoimmune disorder has periods where they're feeling well and they're looking well, and then they have flare-ups. And then they're feeling good and looking well, and then they have flare-ups. So you want to help them reduce stress, prevent and reduce complications. So if you do get an infection, there are secondary complications such as skin breakdown, more impaired mobility. For example, people with lupus often develop rheumatoid arthritis, which is the deforming kind of arthritis to have. It's the one that makes your joints turn in crazy directions. And that can cause people with lupus to lose the ability to walk on their feet, because the toes will be misshapen, or to be able to use their hands properly. So you want to help prevent that, and generally that treatment is reduce the activity in those that limb to prevent the breakdown. Medications are given to suppress the body's abnormal response to stressors. So particularly cortisone or prednisone, it's important to know that children that have these kind of diseases, they're going to get long-term prednisone treatment. That is an anti-inflammatory, and that's why they give it. It suppresses the immunity, but you should also know and teach the family that it's likely to inhibit growth. Children that take high doses of prednisone for long periods of time have stunted growth. It's very common. So that is something they should know. And also apply what else you know to cortisone therapy. So it affects also your blood glucose. It makes your skin thin. It causes osteoporosis. So there's lots of other things that go along with prednisone that you need to inform the family about. Latex allergies are an example of a type of immuno-hyper response rather than an immune deficiency. So, as you know, allergic responses are anything that the body becomes too sensitized to. So, nurses used to be one of the highest groups that had latex allergies, but that's gotten better since they started supplying hospitals with different kinds of gloves, and most hospitals have gone latex free. But it's still out there, and the people that are now at the highest risk for latex allergies are people with neurotube defects, congenital urinary tract infections, and myodysplasia, because they're exposed to latex still. They have direct contact with latex. So the treatment for any kind of allergic response like that is known is to reduce all exposure. So like somebody that's allergic to latex, they can have a dramatic response, but generally it gets worse with every exposure. So if it didn't kill them this time, it for sure will kill them the next time, possibly. So you want to definitely reduce all exposure if possible. And you can use alternatives if possible. Like a lot of patients are allergic to the adhesive in the tape that we use. So generally they prefer the paper tape because it doesn't have the same kind of adhesive. So you want to know about things like that. But some questions that pop up on the NCLEX that are pretty interesting and can take you by surprise and that might not be known is that balloons have latex. So if somebody's allergic to latex items, you might need to educate them. They might not have any idea that there's latex in balloons. Other things that come up on the NCLEX is maybe exposure to bananas. Bananas are in the same family as rubber trees, and latex is formed from rubber. So, you know, maybe if you are talking to a patient and they tell you they're allergic to bananas, then you want to be sure not to expose them to latex because they may not even know that there's a potential for a latex allergy for them. So the type of reaction that you might see in an allergic response is type 1, 2, 3, and 4. You can look up the severity in the textbook. So it goes from mildest to most severe response. It can be just itching and hives, or it can, if it starts to involve the throat, is when we're really concerned of anaphylaxis. So it's as you know, an allergic reaction is an overreaction to some foreign substance. It can be bee stings or what have you. So exposure to that thing could kill them if they're around it again. I have a friend that's allergic to ginger, and if she even smells ginger in the air, she starts to break out. So nursing management, of course, is to prevent them from being exposed while in the hospital, identify and remove antigens, and then provide antihistamines. And then if it's a severe reaction, we give epinephrine. And then the more severe it gets, they may need respiratory support and IV fluid. Because one of the ways to kind of help them from having that deadly anaphylaxis is to keep the blood flowing. When there's a hyperreaction to that foreign substance, the blood can clot. So keeping the fluid going is very important. So some things that a lot of people don't consider or recognize as an allergic reaction can be conjunctivitis in the eyes, spasms in the tear ducts that can be painful. That's actually usually related to an allergic response. Most people don't think about, say, dysuria as being possibly related to an allergic response. Abdominal pain is a frequent symptom of a food allergy that's overlooked. So make sure that you look over this particular slide and try to get an idea of some common allergy responses that could be easily overlooked. This chart from your book explains the differences between type 1, 2, 3, and 4. And so there's delayed reactions that we haven't talked about that, but you may remember from a prior class about giving blood transfusions that they can have a reaction up to a week later or a month later from that transfusion. And that's because whoever you got the blood transfusion from, let's say you're allergic to peanuts, but they ate peanuts that day. That could be an example of how you could have a delayed reaction as your body's working through those antigens that have been introduced. Immune complex reactions. These are immune complexes that are deposited in tissues where they can cause a generalized inflammatory response. So this would be a case where you would see urticaria, wheals, hives, and a lot of times it's associated with a fever or concentrated in the joints. Type 2 is tissue specific, so it depends on what tissue is being affected. For example, the transfusion reactions fall under this one. Type 1 localized, that the example I would give there is say you have the posts, you're allergic to nickel in the posts of your earrings. That's very localized. It's not necessarily systemic, but it can progress to systemic if it becomes more and more severe over time. But so generally, this is hypotension, wheezing, spasms, smooth muscle, stridor, wheals, and you should look up and to remind yourself what wheals look like if you don't remember. Edema, generalized edema, vomiting, diarrhea. So just have an idea of these. So in addition to being allergic to someone else's blood, you can also be allergic to if you get a skin graft or any kind of transplant, like a liver transplant. A lot of times you can get a rejection of that organ. It's called graft versus host disease, but it's basically an allergic reaction to that tissue that you've been given. It can be acute or chronic, depending on the reaction. They may just try to ride the patient through it and treat the symptoms, or they may have a complete rejection. So say it was a lung and the patient was rejecting that lung. Well, you would try a bunch of things to try to suppress the immunity, but ultimately you may have to take that lung out to solve the problem. And so it can affect multiple systems. So just be aware of what graft versus host is.